My name is Dr. Matthew Russo. I'm an orthopedic surgeon here in Scottsdale, Arizona. I specialize in total joint replacement surgery, focusing on the hip and the knee. This video is created to inform patients as well as caregivers about the direct anterior approach to hip replacement surgery and hopefully answer a few questions. We're going to focus on three main topics. The first one is who might be a candidate for hip replacement. The second one will go into a little bit of the technical aspects of the surgery itself. And lastly, we'll discuss some of the recovery after surgery. With regard to who might be a candidate for hip replacement, it all starts with a preoperative visit. Certainly every patient is unique and their pain level is different. We'll discuss things like their x-ray changes, how bad the arthritis is, whether they're bone on bone or is there plenty of cartilage still remaining. How badly is this arthritis affecting their quality of life? Are they using an ambulatory aid? How many anti-inflammatory medicines does it take to rid the pain? And lastly, how bad is the burden of this arthritis? Are they able to do most of their activities on their own, or is this significantly infecting the way of life? The other part of the equation is the patient's overall health. Certainly, factors such as cardiac disease, pulmonary function, and that means the heart or lung issues, are certainly a factor in whether or not they're healthy enough to have an elective surgery such as hip replacement. We have a certain number of clearances we have to go through, and that typically is helped by the medical doctors as well as cardiologists and sometimes pulmonologists or nephrologists even. We have to make sure you're medically optimized prior to hip replacement in order to ensure you have a good outcome. The other thing we look at is BMI. Most places around the country do have a cutoff of approximately 40, and the reason for that is that patients above a BMI of 40 have a significant increased risk of infection. Another factor we look at is diabetes and whether or not the A1C value is controlled, typically below a level of 7. Once all of these factors are under control, then we may proceed with hip replacement surgery safely. Once we've decided you're a candidate for hip replacement, I'll take you through the technical side of things. First of all, the procedure itself takes about an hour and a half to do, okay? This procedure is performed under a spinal anesthesia, where there's a needle in the back. It makes you numb from the waist down, and that allows us not to have to give you so much of the gas and allows you to wake up a little bit fresher and even allows you to go home the same day. The word anterior just means the front of the body in anatomic terms versus a posterior approach, which is more in the back of the body. I have a diagram here which we can we'll discuss and go through exactly how this procedure is performed. Our incision is on the front of the thigh here, which is versus in the back. The posterior approach is more in the buttock, okay? From a posterior approach, you have to cut through all of these muscles, these gluteal muscles, and spread open those muscles this way. And then in order to get to the hip itself, we have to come through all these muscles to perform the hip replacement from the back. Okay. We get around those by coming through the front. We go in between these two big muscles here, okay? This is part of the quadriceps. It's called the rectus muscle here in front. And on the side here, this is called the IT band or the tensor fasciae lata muscle. Okay. We go in between these two big muscle groups and spread open those muscles. And you can see that we visualize the hip nicely through those muscle intervals. Now, of course, these muscles are put on stretch. And what that means for you is that these muscles will be sore after surgery. In fact, a lot of the discomfort after an anterior approach hip replacement is related to how stretched these muscles get after surgery. You feel that all the way along because these muscles go all the way on down to the knee on both the front and on the side. That feeling is very common after an anterior approach, but it gets better pretty quickly and it's still able to get you up walking very rapidly. Once we get down to the hip itself, we make a cut right along the femoral neck. Okay. Once we make that cut, we're focusing then on the pelvis side of things. And so what we do is I take out all the arthritis that's here on the pelvis and ream it out is what we call. We then shape the pelvis to accept the acetabular component. That's the cup. It's made of titanium and has small holes in the component which allow your bone to grow into the implant over time. It typically takes about 3 months for this process to happen, although the first 6 weeks are certainly the most critical. That goes in there just like that. Then we put a plastic component in there called polyethylene. That's the plastic that acts as your cartilage, essentially. There's been multiple iterations of this type of plastic over the years. Over the last 20 years or so, we've almost perfected this in the fact that there's very little wearing out of this plastic piece that we can't even really detect over the last 20 years, and certainly doesn't cause things such as osteolysis and wearing out through the plastic, which used to be a problem before the year 2000. When we're done with that, we then focus on the femur, which is here while we're doing that part of the procedure. We then make a trough down the middle of the canal of the femur. Okay? This allows us to accept the femoral component. This is also made of titanium and also has the same small holes which allow your bone to grow into the implant. Okay. That goes in there snug like that. The last thing we do is we place a ceramic femoral head. Okay? That's the ball that goes on that femoral component, and we put your hip back together. The whole procedure is performed under X-ray guidance. That means that I can use the X-ray throughout the surgery to ensure that all the components are placed correctly and that also the leg length as well as offset is established and matches the other side of your body. That's very important. In other approaches, it's more difficult to ensure that this is accurate. With the anterior approach, because you're laying flat on the table, this is performed with ease. When we're all finished, you wake up with a Band-Aid on your thigh. You can shower immediately and let the water run right over that. I just ask that you don't submerge it underwater. From there, depending if you're at a surgery center or at the hospital, both of those places, you'll be up walking within about 4 hours of your surgery. If you're at the surgery center, we'll then get you ready to go home, and you'll walk out the door to your car. Of course, we'll go over all their discharge medicines and all the things that you need to know, but your surgery is over. Recovery after hip replacement is also individualized based on the patient. Some patients have very little discomfort and require nothing but Tylenol, while others do rely on narcotic medicines. Your recovery will be based on your preoperative pain level as well as pain tolerance. Typically, however, for most patients, the first 5 to 10 days are pretty tough. We do put some numbing medicine around the hip itself as well. This will control your pain immediately after surgery, get you up walking, and most patients feel pretty good. The next day, however, you have a little bit more discomfort than the day before. This is normal. And actually, as the next 2 or 3 days go by, the pain tends to get a little bit worse before it gets better. That again brings us back to those muscles. The muscles themselves swell in the first few days after surgery, and that swelling response is more of an ache or a feeling you get after a bad workout. That feeling resolves in those first few days and is helped by a combination of medications. After surgery, we'll be prescribing Tylenol round the clock, some type of anti-inflammatory medicine to be taken twice a day, typically either Celebrex, meloxicam, or Aleve, as well as a narcotic, typically either Norco or oxycodone, to be taken every 4 to 6 hours to assist with your pain. Sometimes we'll also add a muscle relaxer if you're experiencing some spasms in those muscles we discussed. You'll be on a walker and then transition to the cane in approximately the first 5 days or so. Prior to surgery, we will evaluate your risk factors for developing a blood clot, and we will place you on the appropriate blood thinner. Typically, we use just aspirin, a full dose aspirin of 325 milligrams daily. Other forms are either a baby aspirin, either daily or twice daily. But if you have any history of a blood clot either in the past or have a blood clotting disorder, certainly you will require a stronger blood thinner, such as Eliquis, Xarelto, or even Coumadin. Many people ask about physical therapy. For an anterior approach hip replacement, Typically, physical therapy is not necessary. Exercises, however, are encouraged. You'll be provided an exercise sheet, but they're also available on my website. I encourage you to go through those, but most important is to get you up walking with the walker so you don't fall, and to continue those types of activities rather than worry about specific exercises. We will see you back at 2 weeks to remove that bandage, but until then, you can leave it in place. Unless, of course, some water gets underneath the bandage, we want to know about that right away. We'll take that bandage off and place it with a new dry dressing. Once you see us in the office at 2 weeks, generally patients are feeling pretty good, but you make tremendous progress from that 2-week visit until you see me next time at 6 weeks. At our 6-week visit, we'll take x-rays and evaluate you more formally. I'll watch you walk, and we'll discuss things that you might be itching to get back to, such as the gym or hiking. All those things many patients will have returned to already, but we can discuss them in a more formal setting. The only thing I ask is that you abstain from high-impact activity for the first 3 months after surgery. The reason for this is going back to the implant itself. The implant bonds to your bone, and it takes 3 months for that to happen. Certainly the first 6 weeks are more critical, but in order to ensure that that bonding takes place without having any aggravation or high-impact activity is the best thing for your joint replacement to ensure it survives and you have a good outcome. I hope this video has been helpful in your preparation for surgery and deciding whether or not a direct anterior approach is right for you. Thank you.